Hello.
Hi. There you
Oh,
go. I think I can hear you now.
awesome.
Get my my headphones in. One
Okay.
minute. Good. Okay. Can you hear me now?
Yes, how's it going
Great.
on your end?
It's going well. It's going well. Came to visit my family. Voy a estar en mi meeting. Okay, bye. I came to visit my family, and everyone is kind of like, oh hey. So,
I
and then
see.
my son, he's
So
excited with grandma and everybody. So, kind of borrowing my sister's room. Excuse the mess.
I see. No, I totally get it.
Mm-hmm.
I totally understand. So no worries.
Alrighty. I think I'm all good. Let me just take out my notebook.
Okay, let's get it started.
I feel like I've been having an easier week, but at the same time, I'm usually very like strategic and like I love routines, but I felt like I kind of needed the day off from the holiday. I
Oh,
took
right,
like 2 days off.
That was definitely a thing. Okay.
Already.
How's it going? How did the exam go?
Oh, the exam went well. I got an 85%. Yeah, 85%.
Okay.
So not great, but
So
yeah.
still a B, which is fine. It's not a F or a C.
Oh no,
So
no,
what
no.
we're gonna, I have a bunch of quizzes for you today, so I'm gonna try to get through all of this information as
Okay.
fast as I can.
Okay.
Because I think the quizzes are really helpful, are more helpful.
Mm-hmm.
Okay.
Mm-hmm.
Maybe on Friday, or I mean on Saturday, I'll change it up a little bit. I'll start with the quizzes and then talk through things a little bit more. But
Oh,
today
okay.
we'll just
Yeah.
start with this. I
I think
wanted
that
to
would be
kind of
good.
see, because I know you review during the week, so I was thinking that maybe quizzes might be a good thing to start with in the future.
Mm-hmm. Mm-hmm.
Okay, so I'll just go over PNS and special senses really quickly. The only thing that's not on here for special sense is the ear, but everything else is on here. So we'll finish the special senses on Saturday and endocrine.
Okay. Sounds good.
Okay. All right, so we kind of went through that whole process last week of like, CNS versus PNS, right? And we
Mm-hmm.
said that the CNS was specifically
Like
a
the
part of
command center.
what
Mm.
happened,
You said the command center.
right? But it's more so like it composed of the brain and spinal cord, right?
Mm-hmm.
And then with the PNS, we're talking more about like cranial nerves, spinal nerves, and ganglia. And then we'll talk more about all of those things as well. But the basics three function, and I've kind of just highlighted that here, is conveying motor commands, carrying sensory information, and regulating autonomic function. And we'll break that down too, even more. So starting with what is a ganglion, right? Because I think he's going to test you on this. He probably wants to know what it is. And so basically it's just a collection of neural bodies, right? It's found in the voluntary and anus branches of the peripheral nervous system. And I'll also have pictures on this so you know what exactly I'm talking about. They're kind of like relay stations between neurons. And so basically what happens is that information is going to enter the ganglia, and it's gonna excite the neuron, right? And then it's gonna exit. So it's just a collection of neural bodies, okay? So or glial cells and neuron bodies outside of the CNS, right? This is kind of what's gonna help with like transfer of information, right? So know what that is. And so this is kind of just like examples of what ganglias are, right? So there's three major groups of ganglia. You have the dorsal group ganglia. We kind of talked about that last week, right? It's kind of like a body of sensory information. It is more so like these right here. Those are what they call a ganglia, right? And they have like cranial nerve ganglia. And those are like, for example, this is the trigeminal nerve ganglia. And trigeminal nerve branches into three divisions: your ophthalmic, mandibular, and maxillary divisions. And we'll talk about that more too, because we're going to be discussing cranial nerves here too. But just know that cranial nerves also have their own ganglia. And then there's also autonomic ganglia that's going to be in your spinal cords, depending on whether it's SNS or PNS.
Okay.
Well, what I mean is sympathetic and parasympathetic.
Okay.
Does that make sense? So just to kind of like put that into perspective about why ganglias are important. They're relay stations for sensory information. And this is what I was talking about in terms of like ganglia in SNS and PNS, right? So in the sympathetic spinal cord, you have the ganglias are going to be closer to the spinal cord, which is here, the red ones, right? And then in the parasympathetic region, they're going to be near the ganglia here, right? So just know the differences there.
Okay.
Why these ganglias are important, right? Okay, now I think we kind of talked about this briefly, but he's definitely gonna test you on it because it's on his PowerPoint about this structures of nerves, right? We talked about like the different levels of them, right? So basically you have the, you have the epineuron, which is above, right? Which is surrounding the entire nerve. And you have that essentially is the spinal nerve, right? And then within this thing is the axons, right? Those are the fibers. And then individual kind of axons are what they call fasciculus, right? They're kind of like fascicles, like muscle. This is pretty much the same, just like I was saying before. They named things the same thing, they just kind of changed the name, right? So this exists in muscles. They have the fasciculus there too, right? And then here they have the endoneurium, which is going to be your individual, like your entire, the layer surrounding individual axons, right? And then your peri is going to be your bundles. Your peri is going to be surrounding the axal fascicle. One fascicle has perineurium in it, and then one axon is going to have endoneurium in it, right? Does that make sense? And the entire nerve is going to be your epi, right? Okay, hopefully that makes sense. And then I have like a bunch of notes on the PowerPoint too. All right, so the basic functions of nerve that we have to absolutely know is going to be there. You are going to have your sensory nerves, your motor nerves, right? And your sensory nerves are going to conduct your sensory information like receptors, like from their receptors, right? This is going to be going to the CNS, right? And your motor is going to go from the CNS to the organ, right? So this is going to be sensory. Sensory is you're thinking afferent, meaning going in, and then motor nerves, you're thinking efferent, meaning exiting the CNS, going to then kind of respond to that sense to create action. Does that make sense? Right. So sensory only to the CNS, motor away from the CNS. right? So, and then the cranial nerves that we were talking about, right? I think another thing that I kind of like mentioned last time, like one thing you have to know is that most of these cranial nerves you're gonna find in the brainstem. We talked a lot about that. Remember the rules of force we said,
Mm-hmm.
right? It's number 3 and 4 is in the midbrain, right? And then
Mm-hmm.
in the pons you have 5, 6, 7, 8, and then in the medulla you have 9, 10, 11, 12, right? And then the
Mm-hmm.
only thing that is kind of outside of the brainstem is your cranial nerve 1 and 2, right? And that is your olfactory and optic nerve, right? But everything else
Mm-hmm.
is there. Everything else is kind of branching off of the brainstem, right? So keep that in mind when you're thinking about um, your your cranial nerves and like kind of trying to recall them. Make it easier for yourself. You know, if you learned it through the rules of form, if you think that the rules of four is an easier approach for you, then use that as a, you know, as your kind of supplement or way to make sure that you remember, okay, I know majority of the cranial nerves is in the brainstem, so I just need to derive this from what I already know. And then the rest, you know, are not a part of the brain, are not in the brainstem, which is, like I said, your olfactory and your optic nerve, right? Does that make sense?
Mm-hmm. Mm-hmm.
And then I think the only thing that they kind of emphasize in basic anatomy is which one of these are both are kind of functioning both motor and sensory, and which one is sensory, right? And I think one of the things that helped me remember this before is this mnemonic. Some say marry money, but my brother says big brains matter more.
Mm-hmm.
And when I learned this, it didn't say big brain, it said something else.
Oh, okay.
So I think if you know the rules of force and you can derive these, I think the only thing you really need to memorize is the whether they're sensory or motor.
Okay.
You know, some say marry money, but my brother says big if breast matters more.
Big.
So and then I put like a little bit of kind of like a little bit of stuff on here that are more specific to each cranial nerve. I don't know that he's going to be that specific in terms of like what he wants you to know in terms of specific cranial nerve, but I put it in there anyway, just in case. But I think most likely he's going to want you to be able to identify the cranial nerves and be able to identify whether they're motor or both or sensory. But if he does want you to know the function, obviously olfactory is going to be your sense of smell, right? And I think the only thing that is kind of like that stands out for this is that this is the only nerve, only sensory nerve that does not go to the thalamus for input. Remember, we talked about how the thalamus is the relay center. Most
Mm-hmm.
of these cranial nerve goes to the thalamus to kind of relay their information and then have efferent fibers kind of send their actions out from the CNS to the motor, right?
Mm-hmm.
But olfactory is the only one that do not. So sometimes they test that because olfactory is the only one that's not inputting into the thalamus. Right. So, and then optic nerve, we also, you know, that's your eye cranial nerve. I think the only thing that's kind of cool about this, even though it's part of that cranial nerve situation, but no one really talks about it. You know, it kind of arises from the diencephalon, similar to the diencephalon that we talked about with the hypothalamus, thalamus, and
Mm-hmm.
cerebellum, right? This cranial nerve actually is outside of the brainstem, right? We talked about that, right?
Mm-hmm.
For those reasons. And then oculomotor, this if they ask you anything about muscle movement for the eye, it's either going to be cranial nerve 6 or 3, right? But cranial nerve 3 has pretty much all of the muscles, right? It
Mm-hmm.
moves up the eye, it medially moves the eye inferiorly, and then it also does a superior rotation, right? You most often they try to confuse you with like cranial nerve 3 or 4, right? But know that in cranial nerve 4, they only literally have superior oblique, and then cranial nerve 2 has everything, right? So just remember that cranial nerve 4 has one muscle that is going to be important for, like your eye turning down. So when they give you like a question that's kind of saying, patient looks down and then they have double vision, they're usually talking about trochlear nerve. If they're asking you or saying something about a person that is looking down and out, right? That's going to be like your cranial nerve 3 person. So I don't know that he's going to be that in depth with your cranial nerves. Do you think so?
Sorry, can you hear me now? There you go.
Yeah.
Most likely. Yeah, knowing how his exams are, he wants us to know everything. So
Okay. Well, it's there. I put it on there.
no, thank you. I appreciate it because I'm like, which one is that? Which one does this one? I have to study this one a little bit more.
Yeah, just know like your trochlear is double vision. If you hear double vision, thinks you're seeing, when you look at something, you're seeing number instead of like 2, you're seeing 4. Double vision is 4.
Okay.
Right? That's trochlear. Your number 3 is that's your down and out eye, right? If someone, one of your friends is down and out, they're struggling, think of number 3. This is the eye that's going to have that down and out looking, like funny looking. They kind of look cross-eyed. That's what they're
Mm-hmm.
going to look like. And then your eyes, when they say your eyes dilated is like your pupil is opened up really big. Usually
Mm-hmm.
your pupil is dilated when you get like, when you go to the eye doctor and you get an exam and then you can't see nothing and it's just blurry. Have you done
Mm-hmm.
that before? That means your eyes dilated is open. The same thing happened when you're running from a bear. You want to see, right?
Mm-hmm.
Right?
Mm-hmm.
Okay, so that's, just know that that's happening with cranial nerve 3. And then with cranial nerve 5, this one is kind of big because it has all these different divisions. It's the largest cranial nerve, and then it can divide into ophthalmic, which is which is for the eye, and then maxillary and mandibular. That means it's going to have manifestation in the eye, manifestation in the cheek, and manifestation in your jaw. Does that make sense?
Mm-hmm.
Right? So it's gonna when they talk about like corneal reflexes, they're talking about like putting that that little cotton on the side of your eye when they test.
Mm-hmm.
That's what they're testing. They're testing V1 division of trigeminal nerve, right?
Mm-hmm.
Your chewing is your mastication, your mandible. That's what's going to be involved in your mandibular division, right?
Mm-hmm.
Okay, so if you need to look at those notes, it's going to be on here. I also have like some type of, I also have like a quick quiz on this for you. And then if you absolutely can't remember the rules of force and you can't remember what in the world is going on, this
Mm-hmm.
helps, right?
Mm-hmm. Okay.
Just write this out a couple of times, right?
Mm-hmm.
Here I thought 12 was important because 9 is for both of them are for your tongue, but 9 is sensory and 12 is motor, right? The fact that
Mm-hmm.
12 sticks out like that just tells you that it's moving. 8 is for your ear. Someone's having vertigo, like they're dizzy,
Mm-hmm.
having issues hearing,
Mm-hmm.
cranial nerve 8, right? This eye right here, 4 is when they're seeing, you're putting up 2, but they're seeing 4s.
Mm, okay.
And then 3, the reason why 3 is here is, remember I said down and out, but it's also important for like accommodation. Accommodation means like when you're trying to like, when you tell someone to like, hey, I need you to follow my finger, right? You follow their finger and then you move closer and then forward like that. That's when their eye is like kind of adapting, right? Your eye, you want the person's eye to accommodate to your movement, right? So that's like your, there's these certain, we'll talk about this more when we talk about like the different anatomy of the eye. But the reason why that happens is like ciliary muscle will constrict or relax depending on like if you're going closer or you're going further. But the reason why they have 3 here is because cranial nerve number 3 is important for that.
Okay.
So that's why I don't want you to get confused and like, why is 3 over here, right? Just remember like those eye, you know, when you go to the doctor and they test accommodation, that's what's happening.
Okay.
And then number 6 is for like lateral, like movement, horizontal movement of the eye, right? Sometimes some people's eyes are stuck in the middle like this. That's because their number 6 is not working. Okay.
Yeah, you really see into perspective when you see people out in public.
Yeah, it's kind of like amazing because like when you're going to this stuff and you start like looking at people like, oh my God, you know, I can tell when someone has like thyroid issues or like hyperthyroidism because their eyes just like is almost out there like
Yeah, bug eyes.
yeah, they have the bugaboos.
Yeah.
So
No, for real. Definitely. There's a lot of things I noticed later on when I was working in the hospital. Like I'd see some of my friends, I'm like, your eyes twitching. You're like, are you dehydrated?
you see.
Yeah.
So I think for, so if he does test you on all those different cranial nerves, make sure that you know, you can at least draw this out a couple of times because this definitely helps. And then if the rules of force doesn't help you, but the rules of force is just like 3, 6, 12, you know, and everything else laterally. So hopefully that, you know, make things easier. And then you can just remember that like 1 and 2 is out the blue. Okay, so then we talk about the spinal nerves, right? We talked about last week, we said that, you know, the spine has 8 cervical, 12 thoracic vertebra, 5 lumbar, 5 sacral, and 1 coccyx bone, right? But it's pretty much the same thing when it comes to like, you know, your spinal nerves, right? Your spinal nerve is going to be divided into the same like segments, which is going to be 8 cervical nerves, 12 thoracic nerve, 5 lumbar nerves, and 5 sacral nerves. So there's like an anatomical breakdown of all this, and we'll talk more about that. That can be kind of confusing, but just know that like spinal nerves are mixed nerves. They carry sensory and motor, right, information from to and all somatic body regions of the head and neck, right? So the cranial nerves, we talked about how that is different in terms of like, some of them are both, some of them are sensory, some of them are motor, right? But
The spinal nerves are all of them.
They're mixed, right? So when you're thinking about memorization, just try to just memorize the cranial nerve stuff, right? And then sometimes, you know, if it helps you, you can just take out all the mixed one here, you know, it's all the both to kind of like, you know, include it with the spinal nerve or whatever, and just remember the ones that are sensory and motor. Because like, oh yeah, okay, well, if I don't remember the other ones, like hypoglossal and accessory, those are motor, right? And then another thing that you'll kind of remember here, oh, did I make that? Let me see. 3, 6, 12 on that rules of 4. 3, 6, 12 are motor.
Okay.
Right. And then yeah, 3, 6, 12 are motor. So that's helpful. So you can just like try to remember everything else, right? 3, 6, 12 motor.
I mean, at least that's allowing us to um, process of elimination for the rest.
Yeah, and it helps because it makes sense. Like 3, accommodation, it has to move. Your lateral 6 has to move, right? 12 is the tongue, has
Oh
to,
yeah, that has to move.
yeah. And then everything else seems like it could be sensory, like 8, if you can't hear or you're feeling, dizzy, things like that. All right, so the spinal branches. So these ones can be a little bit confusing, but I want to try to break this down for you. So obviously we're thinking this is the spinal cord, right? We talked about the different type of ganglions, and we said that that's like a collection of neural bodies, right? They're important for sensory inputs, right? The rootlets that we're talking about, these little rootlets are these little things here, and then they form to make your, oh, my iPad just died. It's not good. And then they form to have your dorsal root, right? So rootlets come together to make your roots, right? And then your rootlets, your roots, not rootlet, rootlets come together to make your roots. And then your roots are going to come together to make the spinal nerve. Remember we said the spinal nerve. So this is like, so let's say this is the rootlets came together to create the roots here. And then the roots came together to make the spinal nerve here. And then the spinal nerve splits to make your ramus. They will either go dorsal and ventral, right? Dorsal means back, right? So your dorsal ramus is going to coincide with your dorsal root ganglion, right? Right? And so you have your ventral root right here, right? That's going to come together and make spinal nerve, and then it's going to branch off to make your ventral and or anterior rami. Does that make sense?
Yeah, that makes sense.
Okay, so I'm glad that you were able to follow that.
Yeah,
And
the
then,
pictures explain a lot too. I understand better.
yes. And then, just kind of the general rule, right? When we're talking about dorsal, we're talking about like
Back.
Yes, the back, right? And these are going to be like your dorsal rami is going to be innervating like your deep muscles of the back for motor control, right? So it's going to be like your erector spinae, right? And then your ventral rami is going to be like your thoracic region, for example, right? That's not all of it, but that's just some of it, right? We're just talking about specifically the ventral, the thoracic region, which is going to be your, for example, your intercostal nerves, and they're going to run deep to the ribs, right? And they're going to, and they're going to essentially provide like a sensory input. Okay, so. Okay, let's see. Okay, so, all right, so that was that for spinal nerves in terms of like what absolutely you need to know, right? Dorsal rami is extending dorsalis posterior. They're gonna have the somatic sensory and somatic motor axons, right? And then they're gonna carry the somatic sensory from sensory receptor to the dorsal surface of the body, right? And then your ventral rami is gonna be your anterior, right? And they're gonna be carrying sensory, somatic sensory from sensory receptor on the front side, the ventral and lateral surfaces of the body, right? And then that's also going to be like your information for skeletal muscles and lateral surface of the body. So just remember that the back is going to, dorsal is going to get that sensory information from the posterior portion, right? Right, that's why your deep back muscles, motor control, things like that, that makes sense, back with the back, right? And then when we're talking about ventral rami, when you're talking about like the abdominal wall of the muscle, that's because it's going to be ventral, is anterior, and it's front. Right, so it's kind of just like orientation is important in making that connection in terms of like why those sensory information is going to be coming from the back, right? Because it's going to be the back, the dorsal portion of the spinal cord is going to receive, posterior information from the back muscles versus the ventral, which is anterior, which is going to be your front ventral abdominal walls.
Okay.
Okay. All right. So, and then here's another thing that is kind of very complicated is what we call the nerve plexuses. There's 4 of them. You have your cervical plexus, your brachial plexus, your lumbar, and your sacral plexus. Right. I put a picture on here to kind of talk about, your ventral, your cervical plexus is going to be right there up your neck, right? These are kind of like nerve bundles, right?
Okay.
And this one is going to be underneath the sternocleidomastoid, right? And I think what they want you to know for this one is, your cervical bundle is usually going to be C1, C4, right? But there's kind of something important here to know because phrenic nerve, even though it's part of your cervical plexus, they have this thing called C3, C4, C5 keeps the diaphragm alive, which is the cervical nerve. I mean, your phrenic nerve, right?
Okay.
C3, C4, C5 keeps the diaphragm alive, right? Compared to just your regular cervical, which is pretty much all of this, the cervical vertebra, right? But your phrenic nerve specifically, C3, C4, C5 keeps the diaphragm alive.
Alrighty.
Does that make sense? Okay, now your brachial, man, it took me a whole, brachial plexus is no joke. I hope he's not gonna anyway, brachial plexus is, so it's pretty much like kind of your innervation for all your upper limb, right? Right. And so the way that I remember brachial plexus, like what essential nerves are important for this is, let me just say this. So, okay, let's see. I literally have a way to draw this. And then, so you have, right. And then you probably don't need to know it at this level, but what you do need to know is that you need to know Marmu, right? Marmu, this is going to be your musculocutaneous, right? And this is the same thing. I'm just drawing it differently, right? This is the same thing here. You're just saying Marmu, right? And so, and then this is axillary, radial, median, and ulnar, right? And ulnar is going to be like your C7, and then here is C5. So that's going down like that, right? Does that make sense? So no Marmu, muscular, axillary, radial, median, ulnar, right? Okay, so that's pretty much like the important things to know about brachial plexus. And then I think another thing that might be important, and maybe he'll ask you guys, is, I mean, he doesn't explain it enough in the PowerPoint and or his notes. So I'm thinking that he won't test you on like different movements in terms that are associated with these, if they're lesioned, right? But essentially, like for ulnar, there's always going to be like this thing called like Erb's palsy. And it's kind of like the waiter's tip situation. In the waiter's tip situation, if you lesion your ulnar, it's just like someone who's kind of stuck like this. It's like waiting for a tip that's never gonna come.
Yeah.
And then your musculocutaneous is flexion of the bicep. And then axillary, this is like when someone, you know, when someone injures their leg and then they have to have crutches, right? Those patients will have, they can develop axillary lesions, and they can lesion the underneath their armpit is the axillary nerves. So this is why, like, you know, these different nerves are important, just because this is your upper kind of extremity nerves. And different lesions can manifest depending on which part of the nerve you're damaging. But just, you know, because it's basic anatomy, just remember to kind of say marmu and know that musculocutaneous, axillary nerve, radial nerve, median nerve, and ulnar nerve, right? And median nerve is always going to be on your right side. Ulnar nerve, I'm saying on the right side because your radius bone is on this side, right? And then your ulnar bone is on this side, right? So your ulnar nerve is going to coincide with your ulnar bone, right? It's just going to travel this way, right? Median nerve is always going to be like the first three fingers, right? And that's also kind of associated with like carpal tunnel syndrome. Right. And then if you kind of if you break your arm, your forearm right here in the middle, that's when you can your mid shaft humerus is your radial mid shaft humerus is your radial nerve lesion. So that's that. I'm not gonna keep harping on it. And that's for your brachial plexus. And then your sacral, your what is it? Your lumbar plexus are your bundle of plexus on the lower end of your body, right? These are important for many different reasons. They're going to be from your L1 to L4, and they're going to be important for like your anterior lower limb, like your femoral nerves, right? And those are going to be like your ilio hypogastric, your ilioinguinal, your genital femoral nerve, your lateral femoral cutaneous, your obturator nerve. And all these nerves are associated with different types of lesions as well, just like your brachial plexus. So your ilio hypogastric, that's usually when you think of like, that's usually damage when someone gets an abdominal surgery, right? Because the ilio hypogastric is kind of high right there on your inguinal, kind of in your iliac crest kind of region, right? So if someone gets an abdominal surgery, they're going to have like sensation problem. They're not going to be able to feel anything on kind of like that iliac crest part, right? And then your genital femoral, this is really kind of easier to remember because if you don't have that, if that is damaged, if you test someone's testicles, they're not going to like retract.
Yeah.
So they lose like the cremaster reflex. And then for lateral femoral cutaneous nerve, this is kind of like, you know, like the side of your leg. And usually people that get this problem is like when the people that are kind of obese and they're wearing really like tight clothes. Okay. Does that make sense? I feel like those are like the most highly tested ones. But I think for this one, all he wants you to know is be able to identify what those nerves are more likely. Your ilio hypogastric, your ilioinguinal, that makes sense, right? Your iliac inguinal, kind of right there, ilioinguinal. Your genital femoral is going to be right there, kind of on the inside between your genital and your femoral nerves, right? Your lateral, follow it to the side of your leg, your lateral femoral. Cutaneous, right? Your obturator, you're going to have that obturator canal. Like follow that, you're going to find an obturator nerve, right? Does that make sense? And then you have your sacral flexes. And this is kind of, interesting too, just because your sacral plexus, most often these get damaged depending on, like, for example, have you heard of like the Trailenberg sign?
Mm-mm.
This is like when someone gets an injection on their butt and then they hit a nerve and then now they're like limping.
Oh, wow.
Yes, and that's more so like associated with your superior gluteal nerve, right?
Mm-hmm.
But that's essentially like part of this, the sacral plexus. And then you have the pudendal nerve. Pudendal nerve is like, if I know you guys have gone over bones and you have your ischial tuberosity. Usually when people need a nerve block, when they're giving, sometimes if it could be birth, or if someone's having issues with like kind of controlling their pelvic floor,
Mm-hmm.
they'll kind of look for the tibial tuberosity, and then they'll find the pudendal nerve there and kind of numb it.
Oh, wow.
Yeah, so the pudendal nerve is important. You have your sciatic nerve, right? Your sciatic nerve is important. That's most likely the most common issue that happens in sacral plexus, right?
Mm-hmm.
We hear about that one a lot, right? And then your sacral plexus is going to kind of differentiate into like multiple different types of nerves, like your common fibular, your tibial nerve, your sacral dipular nerve, and that's also going to like have different manifestations. Like, I don't know if you heard of like foot drop.
Mm-hmm.
When like someone's having, limping on their ankle, right?
Mm-hmm.
That's more so associated with like common fibular nerve. And I kind of just put all this kind of pictures on here so you can follow, because the brachial plexus sometimes, they can come from, like, for example, the brachial plexus, they can come from the neck, but they can kind of extend all the way up from your proximal to your distal forearm, right?
Mm-hmm.
I mean, as you can see right here, like this is your radial nerve. Remember we talked about the mid shaft fracture. Your radial nerve is like, uh, if you get a fracture right here, that would be your mid shaft fracture. The patients that are going to be on crutches can damage your axillary nerve, right? Your median nerve, remember I said the first three. Median nerve could be your carpal tunnel. Your ulnar nerve is going to be where your ulnar is. Your musculocutaneous is going to be that, like, on that forearm right here, right there. And that's going to be like your brachialis, your bicep brachii. That's why it's going to be involved in like flexing, right? Flexing.
Mm-hmm.
And you're going to have like that weakness in kind of moving your arm up. So that, I think that's like the important thing about those things. That's why I put that on there. I don't know how beneficial it's going to be, but if it is, for if you whenever you guys do a final exam, if it is something that might be helpful, it's good to kind of look at like what nerves are kind of influencing different areas. And then this one talks more about the lumbar flexus. I don't think I put the sacral ones on here. I meant to put the sacral one on here. But like I was saying, the obturator is going to be that little area right there, while your femoral nerve is going to be almost, up to the down of your leg, right?
Mm-hmm.
But you're going to follow that with kind of looking at, this femoral nerve branches here, which is L2 to L4, then it's going to kind of break off to iliacus, sartorius. Like these are all the muscles that's going to be involved
Affected by that.
with the femoral nerve, right? These are your like quad flexors, right?
Mm-hmm.
And then same thing for like obturator nerve. So I put this on there so hopefully for it to be helpful. And then your common fibular nerve is gonna go all the way down here, right? That's why when you think about someone having foot drop, they're not gonna be able to like dorsiflex, right?
Mm-hmm.
or plantar, and then tibial is going to be like TED, right? This is going to be tibial, eversion, dorsiflex, and then femoral is going to be PED, which is going to be peroneal, plantar eversion, right? So this is going to be like your foot drop, meaning like they're not going to be able to plantar flex their foot. So those are just little mnemonics that I use to remember them. And I'll send those to you too.
Okay.
Okay, now let's keep going. All right, so now you have the different branches of the PNS, right? You have the motor division, you have the sensory division, just like we were talking about. You have the, with motor efferent exit, that means it's going to go from the CNS to the rest to your motor function, right? You're going to have your ANS, your motor innervation in the smooth, cardiac and glands, and those are just going to be involuntary, right? You can't control your heart, you can't control your stomach, right? Those are you can't control your sweat, right? Those are glands are what I'm saying when it comes to sweat. And they have this dual innervation that's going on here. And I saw this on his PowerPoint where he's kind of explaining that they have this dual intervention, meaning that if you can increase and lower the heart, right? You can increase the heart rate via sympathetic, you can decrease the heart rate via parasympathetic, right? And then your motor efferent division somatic nervous system, that just means that this is things that you can control, right? So there's somatic nervous system, meaning you can control it. This is gonna go specific to your skeletal muscles, like when you're working out your arm, right, at the gym. That's going to be things that you can do, right, for motor nervous system, right? But your autonomic is going to increase your heart rate, your sympathetic version, right? Your cardiac, right, muscle, right? But while you're running, right, it's going to kind of slow down your parasympathetic, right? Rest and digest, right? So when you're thinking about motor efferent division, just think about that, right? Somatic nervous is voluntary, autonomic nervous system is involuntary. When you're at the gym, you're increasing heart rate, decreasing rest and digest. Somatic, when you go and essentially try to, lift up a dumbbell, right? And you're trying to like do skeletal muscle reflexes, gym, workouts.
Okay.
Right. So and this is just summarizing all of that. And I think he also mentioned like ALS in the PowerPoint, kind of just talking about that, like, these, they have the motor division is essentially going to, when you have a damage in the motor division of the PNS, you're going to have uncontrolled movements, right? That's what ALS is. They will have upper motor neuron damage and lower motor neuron damage. And upper motor neuron damage just means that they're going to have continuous movement like this, that they're not like spastic muscle movement, they're not going to have control over. And then lower motor movements are kind of just fasciculation, like tongue movements that they can't control. So ALS, no, that is both upper and lower motor lesion or upper and lower motor neuron, like kind of like symptoms. You put that on there, I think. Yes, I do remember that, ALS. Okay, and this is just kind of the same thing when we're talking about ALS. It's more so specific to like the different tracks that we talked about. Remember when we said cortical spinal tract, the dorsal lemniscus tract, and for ALS, it's going to lesion the cortical spinal tract, which is going to be your spastic movement, right? And then That's essentially going to be like the homunculus too. The homunculus is in the brain. And the homunculus is pretty much telling you that different slices of the brain is going to correspond to different portion of the body. For example, hopefully I'm explaining, this is, well, let's say this is a slice of the brain, right? We're going to say that this part is going to be your limbs, right? This part is going to be face. This part is going to be hands, right? And, or just saying like upper extremities, right? So if for some reason they get a lesion right here in the middle, because this is how this other side of the brain, right? For some reason they get a lesion right here, that's going to manifest on the
Same side as everyone else.
it's going to be on the other side, right, of the limb, of the lower, right? So let's say this is the left side, right? That means that on the right limb, right legs, right? Right legs is going to have weakness, right? So when we're thinking about like right leg with weakness, we're going to even think about like, okay, this, we're thinking about the lower body here. Not only will they have weakness, they're going to have issue controlling their pee, right? We're talking about lower body here, lower body sensory issues, right? This patient is going to have like urinary incontinence, right? And this is like, you know, when you see someone get a stroke and for some reason they're having urinary incontinence, they have weakness in their leg, it's because it's on the, like right here on the kind of very and medial part, right? Because as you go this way, right, this is medial, right? And this is lateral, right? So when they say that they have like a lateral like lesion right here, now you're talking about the upper extremities, right? That's going to be upper arm weakness, right? And then the face, that's they're going to have facial, like right here in the middle, right? They're going to say, you know, probably medial. Sometimes they like to say medial lateral, yeah, they say little medial lateral, and that will be like the face. But the hands and the face is really close together. So sometimes you'll see face and hands on this manifestation. But usually if it's really at the very middle, right here, you're talking about legs, laterally, it's the hands, right? And it's always contralateral, meaning opposite side, right? Just remember that when you're talking about the brain, it's always going to be right is left and left is right. Hopefully that makes sense. I remember taking neuro, and every time I took a test, I'd be like,
yeah.
He's always like, just make sure. I'm like, okay. And it's the same with the eyes too. Okay, so we're talking about motor division. We said this already, right? So the motor division, I kind of just broke this down a lot more, right? Because there's in the motor division, we said that there's the involuntary, and involuntary is just going to be your SNS and PNS, like your fight or flight and rest and digest. So I just gave you more information there so that you can kind of use it as an information, right? And then also another thing they love to test this, pay attention, is that this sympathetic branch is going to have neurotransmitter and hormones. And the hormone part is going to come from the adrenal gland, right? The adrenal gland has different layers that's involved in secretion of hormone like aldosterone, cortisol, androgens, like your steroid hormones. That's why the sympathetic branch is going to have hormones, but the parasympathetic branch is not, right? Your sympathetic branch is also going to focus on neurotransmitter, right? So what makes them the same is that they both do neurotransmitter, but sympathetic also does hormones, specifically with the adrenal glands. And the adrenal glands, it's kind of like a direct input, right? Because they have the preganglionic neurons and they have the long postganglionic neurons. With adrenal glands, they only have preganglionic, okay? And they like to test that one. Just remember, if you don't remember anything else, adrenal only has preganglionic neuron and is stimulated by acetylcholine. Most of the neurotransmitter in this section is acetylcholine. That is it. Acetylcholine, majority of it is acetylcholine, right? The only thing that makes this difference is in the postganglionic part. It starts to change in terms of the neurotransmitter, right? Because in order for us to stimulate heart rate, right, we're talking about epinephrine and norepinephrine. That's the only thing that it changes, right? When we're talking about the postganglionic, but everything on the preganglionic, I hope this is making sense, right? When I'm saying post and preganglionic neurons, I'm talking about it this way. So we say in sympathetic, SNS is going to have a short preganglionic, right? And then this is going to be your postganglionic, your preganglionic, right? All the pre's are going to have acetylcholine as their neurotransmitter, right? And then in the sympathetic, there's going to be some of them that's going to be secreting norepinephrine and epinephrine, and that's going to help with your sympathetic heart, right? Heart rate, things like that, right? So just remember, sympathetic, short, preganglion, long post, right? Long post, short, and it's the opposite with parasympathetic, right? Long pre, short post.
Okay.
And they love to test that. They stay asking this because we forget, right? And the reason why they have short posts is because they're close to the target, right?
Okay.
Yes, they're close to the target. And then the SNS, they have long posts because they're further away. They have to travel further, right? So just remember, the majority of them preganglionic, that means before they reach their target, before they reach their target, it's going to be acetylcholine is going to be their preganglionic neurotransmitter. It only changes when they get to the postganglionic, right? And it's going to be norepi and epi for sympathetic. There's always an exception, and I hate to say this, except for the sympathetic sweat glands. The sympathetic sweat glands is going to be ACH preganglionic and ACH postganglionic. Okay, those are the important exceptions, the SNS sweat glands, and the adrenal. The adrenal is going to be ACH, but then it's ACH pregang, but it's also going to be releasing directly NE and norepinephrine and epinephrine, and this is going to stimulate. Actually, no, I'm saying that wrong. They're going to secrete this, but the ACH is going to stimulate aldosterone, cortisol, and androgen. And this is hormones that is related to sympathetic, and we'll talk about this a lot when we get to the endocrine gland, but you might not, just, hold off on knowing this. I just wanted to introduce that.
Okay.
But this makes sense, right? So I think those are the important parts there. But if you are in doubt and you don't know what neurotransmitter it is, majority is acetylcholine. All right, and then the sensory afferent division, this is gonna be like your skin and your visceral organs, right? This is gonna be your mechanoreceptors, right? Those free nerve, those Meissner, corpuscle, like those are, I put them all in here, which is on your PowerPoint, right? This is when we're talking about sensory afferent. Afferent is sensory coming in, right, to the CNS. Right? Because motor is away to the CNS, right? The motor one is going to be the one creating the action. Now, the sensory afferent division is going to be responsible for sensing all the outside stuff and then sending it to your brain. It's like, oh, you got pinched. I need to send my brain, I don't know, your pressure receptors, your mechanoreceptors to let them know that, like, oh, I need to let my brain know that I'm feeling some pressure. So those are going to be more specifically to your mechanoreceptor and your internal visceral organs, right? So that's all your afferent sensory division is all about. Your motor is kind of the big division because sensory is just like one thing, but then your motor division is going to have that sensory, your somatic, and then your ANS, right? All right, you made it to the special senses. Okay, so let's start with the olfactory, which
Mm-hmm.
is your um, your cranial nerve number 1, right?
Mm-hmm.
All right, this is your nose, right? So your olfactory is going to detect your sense of smell, and what they're going to detect is what they call like odorants, right? And they're going to have different receptors, just like you have receptors, mechanoreceptors, sensing pressure, sensing different type of stuff that you feel in your finger. Your olfactory or your different type of senses are also going to have receptors. They're going to be responsible for detecting molecules associated with that sense, right? We're talking about smells, which is going to be, there's going to be olfactory receptor that's going to be sensing those odorants,
Mm-hmm.
right? And then this is just kind of a picture about, I think what he kind of wants you to know a little bit, right? In terms of like the structure. I think I saw a question in his PowerPoint when he talked about like, where do you find like the olfactory organs, right? And I think he wants you to know that that's like within the lamina propria, right? This is the olfactory organ right here, and
Okay.
that's in the lamina propria of the connective tissue, right? Right.
Okay.
So so another thing about the lamina propria, which is why it's important, is that they have the blood vessels in there. They have the nerves and the olfactory organs in there. That's why it's important, right? Your olfactory epithelium is going to have 3 cell types that's going to be important. It's going to be your basal epithelial cell, your supporting your supporting cells, and your olfactory receptor cells. Remember I said most of these senses are going to have their own receptors and are going to be involved in sensing and detecting odorants. So your basal cells are always going to be your stem cells, right? Because if for some reason your olfactory cells get destroyed, stem cells are going to come in and they're kind of regenerate and renew, right? Your supporting cells, they're going to try to like, if supporting cells are always important, they exist everywhere. They exist in the brain, right? We talked about the microglial cells. Those are going to be kind of killing all the old stuff, like the debris, so that your other cells that are healthy do not get kind of infected, right? So the supporting cells are also going to exist for the olfactory cells, right? And then you have your olfactory receptor cells, which is pretty much like the main cells that is important for, detecting those odorants. And the main function or the main structure that they have in order to do that is what they call a cilia, right? The cilia is important for like your mucus layer on the surface of the epithelium. They have those receptor proteins that we've been talking about that are going to bind and detect the odorant, right? The cilia is kind of like those little hair-like cells, remember?
Mm-hmm. Mm-hmm.
And they're going to help with the mucus in the mucus layer, right? And the reason why that's going to be helpful in detecting detecting the odorant is because they're going to trap those little stuff, right? They're going to make them stop, and it's like, hey, 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 hey,
Smell this.
right? And then they're going to send those different signals, like, the olfactory nerve, because that's the whole point of this. You have your olfactory nerve that's then going to kind of receive those signals, right? Through the cribriform plate, right? And I'm assuming you guys saw in your head and neck, maybe bone lecture, where you guys got to see the cribriform plate.
Mm-hmm.
Okay, all right. I think that's what's high yield with the special senses, right? Do we agree?
Yes.
Okay, so let's talk about like your gustation. And gustation is just short for, or not short for, but like it's just another name for taste, It's literally on the PowerPoint.
Mhm.
So you detect taste molecules, right? In the dissolved saliva, just like I was saying with the olfactory special sense, is going to be the same thing here. You're going to have receptor proteins that's going to be specific for taste, gustation, right? And then to make it easier, your gustation or test is going to be called, taste is going to be called your gustatory cells, right? There's going to be your gustatory cell. And then you also have your test papilla, which is kind of like the most common test receptors located in the taste papilla, right? And I think what's important with the gustation is that you have these 4 types of taste papillae, right? But first, the oral cavity is going to be covered by stratified squamous epithelium. This is going to be like most of your epithelial cells, right? Your lung, I mean, not your lung, your esophagus is lined by stratified squamous epithelium, right? And then you have those 4 types that he wants you to know. You have the filiform papillae. These are the ones, they do not contain taste buds. They do not contain taste buds, right? These are just an accessory. Cats have these. They use this to like to stick to stuff. You know how like cats tongue are kind of like rough.
Mhm.
This is why filiform, they have a lot of those. They don't contain taste buds. They are not for tasting. You have fungiform. I don't, can you see this? This is like the
Mhm.
filiform papillae, right? Your fungiform has 5 taste buds on the apical. So this, your fungiforms are in the front, right?
Mhm.
And then your syncrevent papillae, it contains the most taste buds, right? Your circumvent, did I put it over here? Circumvent or it's gonna be here. These things that,
This reminds me of like high school. I had a friend that was like, "Oh my gosh, what is wrong with my throat? Can you look inside?" She thought she had like an STD or something. Look at the back of my throat.
it's probably stress herpes.
Yeah, or something. But then I was like, "Oh, look, like yeah, it's so funny. We had like a bio class and they were kind of showing something like that. She's like, "Oh, I guess it's normal. It's supposed to look like that in the back of your throat."
Oh
Well, you should go
yeah.
get that checked out just in case.
It is very disgusting when you look at it.
Yeah.
Okay, so
Mhm.
just know here, I think what stands out the most is this filiform,
The
because
first
they don't
one,
have it, and then this one has
everything else,
all. And then, fungiform and
fine.
foliate papillae are pretty much kind of, they have 5 to 10 test buds. So they're kind of like very similar, right? But
Uh-huh.
filiform papillae and circumvent papillae pretty much have the kind of similar kind of description in terms of like the type of gustatory pore types of taste papillae that you have in the tongue.
Mm-hmm.
And then taste buds also have their own collection of cells, right? You're always, like I said, you're always going to have like the basal cells, you're always going to have some type of supportive cells.
Yeah,
Um,
everything has a layer.
yes,
You have
yes. So
something, then that has layers, and then that has, yeah.
exactly. And the thing is, like, you need those basal cells because we know for sure that, cells die and they need to kind of regenerate themselves at some point, right?
Mm-hmm.
So yeah, you're gonna always have the support cells, and their job is always gonna be trying to, you know, get rid of old stuff or get rid of stuff that is not supposed to be there, um, like debris and something that can possibly cause infections, right? They call that
Mm-hmm.
transitional cell in the taste buds. So just know that there's always going to be 3 things. There's going to be stem cells, supportive cells, and the actual cells that's important for sensing the actual taste, right? Kind of like with olfactory, they have the olfactory cells. Now, in the taste buds, you have the gustatory or taste receptor cells that's going to be involved in sensing the taste molecules.
Mm-hmm.
And I think here what they want you to know is there's going to be 5 taste receptors, right? You have salty, sour, sweet, bitter, and umami receptors, right? Umami is your glutamate, they sense glutamate. And then another thing that's kind of conventional here is that your sour is going to detect your citric acid and your vinegar, right? So citric acid, vinegar, acid, sour, right? I think he had like a practice questions on that, practice question on that. Which taste receptor is going to sense acid or vinegar.
Mm-hmm.
And then glutamate is going to be your umami. And then I put it right here, pretty much like what sends different receptors, or what receptors sense different things. Okay, and then just like the olfactory nerve, you are going to have a gustatory pathway, and this is going to be involved in the cranial nerves we were talking about, right? We said when we talked about the rules of force, we have 9 for taste, right? Cranial nerve 9 specifically for sensory and taste, right? So you're not going to see 12 here. Why? Because it's motor, right? So your afferent taste, your afferent is going to be cranial nerve 7, right? The rest is going to be carried by 9 and 10, right? And I don't think you have to be this specific, because like when we learn it, they always tell us like that, 2/3 anterior and 1/3 posterior, 1/3 posterior sensory and taste is going to be cranial nerve 9, 2/3 anterior is going to be cranial nerve 5, 3, and cranial nerve 7, but that's too specific. I think all he wants you to know here is that your afferent, your signal that is coming in when you taste, that's going to
here.
be your cranial nerve 7, right? And then what's going to carry that to the brain? That's going to be your cranial nerve 9 and 10. And that's the same that's happening here, right? So just remember that. And then this, I guess, it does kind of say it here. I guess you can see what I was talking about a little bit, because your cranial nerve 9 is posterior, cranial nerve 7 is anterior.
Okay.
Yes, but it just know that they're both part of the process.
Okay.
Okay. All right. So now the eyes. I think this is the last part. The eyes. And then when we're talking about the eye, this is, for example, just the external eye. We're talking about like the sclera, the white part of the eye. Right? Our eye's job externally is to be able to convert light to images, right? And the eyes is a little bit weird too, because it's kind of like, it's part of, it's not kind of, it is part of the brain. So, what's right's going to be left and what's left's going to be right. So they kind of have the same like manifestation. Like if you have a lesion in the bottom, it's going to show like you're blind at the top. Yes. And if you have like a lesion on the left, it's going to show like you can't see how, like it's going to show on the right side. Okay. So the anatomy of the eyeball, right? I think the only thing he wants you to know here is that it's kind of irregular shape. They have this spheroid shape. I mean, you can tell, right? They have like this weird shape, the eyeball. And spheroid just means kind of circle, right? Sphere. And then surrounded by that is like fat, right? Because we know you have a lot of cushion and support in your eyes. So you would want that, right? Compared to like someone who has hyperthyroidism where the eye is kind of like coming out. Right. Okay. So the structure of the eye, you have like a bunch of stuff here. The accessory around your eyes for what? Protection, lubrication, support of the eye, right? Your eyelids or palpebrae. If he doesn't use eyelid, know that palpebrae is the same thing, right? That's going to be for protection of the cornea of the eye, right? You're going to have your medial and lateral canthicus angle, and that's just like these two things, like your medially, right? Just follow like whether in the name, they usually use middle to the middle, medial, lateral to the lateral. And that's the same thing with eye movement. They'll always say like, medial movement and lateral um, uh, I think movement as well. So when your cranial nerve 6 is moving this way, they call that lateral.
Mm-hmm.
So that's the same thing. They have the lateral canthus angle and the medial canthus angle, which is kind of just like the surface covering of your eye, right? And then the palpebral fissure, or the slit between the upper and lower palpebra, which is kind of like that. So you have so this is your palpebral fissure. This is this between this thing too. This is the medial and lateral angle, right? This is your eyelid, which is the same thing as the palpebra, right? This is your iris, right? Your
Mm-hmm.
eyelashes is for like protecting you from, you know, those little molecule particles, right?
Mm-hmm.
Okay. Um, so those are important to know, because maybe um, and then okay, and then I think he also kind of emphasized this, the pink eye inflammation in the conjunctiva, right? This is going to be like your conjunctiva is going to have two layers. They're going to be the layer of the conjunctiva covering the inner surface of the eyelid, right?
Mm-hmm.
The bulbar conjunctiva is the anterior surface of the eye, right? So when you get an inflammation, we're talking about those layers that is being inflamed specifically.
Mm-hmm.
So if they ask you what's being inflamed in conjunctiva, just know that those two layers are going to be involved: palpebral conjunctiva and bulbar conjunctiva.
Mm-hmm.
One is inner and other is surface. Surface just means top. And then the lacrimal apparatus, this is just specific for like tears, right? This is going to produce your, they're going to produce, secrete, and create current tears, right? When you're
Mm-hmm.
crying, this is where it comes from. Your lacrimal gland, right? The glands are right here. Can you see me annotating stuff or no?
Yeah, I see your mouse.
Okay, so this lacrimal gland, right? They're going to be superior and lateral, like this is
Mm-hmm.
medial. Well, this is medial, middle, lateral. They're going to be superior and lateral to the eye, right? And then um, you have your lacrimal punctum, right? They're gonna drain into the caniculi right here. Like, I don't know if you see that, it's kind of tiny,
Mm-hmm.
right? This is the caniculi, right? And then the lacrimal sac is right here. It kind of has like this inferior portion that's gonna be your duct, right? And it's
Mm-hmm.
gonna like drain tears into your nasal cavity. So when you're crying and you're trying to figure out why you have sinusitis, it's because that's what happens. you
Yeah, I get really sensitive with certain makeups, like
yeah,
eyelash, mascara, and eyeliners.
exactly.
Yeah, I'm like, sheesh, I can't stop crying. Can I take off my makeup?
Yes. Okay, now you have the internal eye structure, right? So you have the
Mm-hmm.
sclera, which is the white part of the eye. Um, and someone has like connective issue problem, like someone who has like osteogenitis imperfecta, they're going to have like blue sclera because they're going to have impairment of the creation of that dense connective tissue in their eye, which makes them blue instead of white.
Okay.
And then your cornea is the interior of the sclera, right here, right?
Mm-hmm.
Right, and that's going to be fibrostenic, right? This is going to be transparent, right? This is going to have lots of nerves, but no blood supply. This no blood supply stuff is important. They like to do that. They like to ask about that. And then the choroid, or vascular tunic is going to be the middle layer of the eye. This one is going to have your blood vessels and lymphatics, right? That's why it's called the vascular tunic, right? It's going to have the iris, your ciliary body, your choroid, right?
Mm-hmm.
Right. Okay. So let's see. Oh, I need to get, but yeah, just remember those. Make sure you know where what part has no blood supply and what part has blood supply. And then layers of the eye, right? You're gonna have your ciliary body, which is the muscle, right? You can't really see it here, but it's essentially like right here, kind of to the back of the lens here,
Mm-hmm.
ciliary body. And they, in the ciliary body, they have what they call suspensory ligaments. And the ciliary
Mm-hmm.
body is the actual like, it's kind of like the muscle, and the suspensory ligament, when you accommodate the eye, is going to pull, right?
Mm-hmm.
And then relax. So
Mm-hmm.
that's why the ciliary body is important, because it's going to be involved in like muscle contraction and relax to change the shape of the lens.
Okay.
And which is kind of like the process of accommodation. Remember we were talking about, like, when someone follows the eye back and forth. Now this is where that comes in, right?
Oh, okay. From the ciliary body.
Exactly. So when the muscle is contraction, that means that the suspensory ligament is pulling the lens, right? And it's making it kind of biconcave, right? And it's making it contract, right? Compared to when it's moving forward, and it's gonna make it relax.
Mm-hmm.
Right. But again, just know that that's associated with accommodation, right? Remember, we talked about earlier, when we're talking about ciliary body suspensory ligament movement and the contraction and different changing the shape of the lens, we're also talking about the cranial nerve 3, right? Because we talked about
Mm-hmm.
how cranial nerve 3 is important in accommodation, right? So what else? Lens, we talked about, that's going to be your transparent biconcave disc, right?
Mm-hmm.
Right? That's going to be the one that's changing shape with accommodation, right? And then the iris is going to be the pigmented platen ring anterior to the lens and posterior to the cornea. So we'll talk about a lot more about that in terms of like the structure of the lens, and the different cells that's associated with that. So just know that the iris is going to have your blood vessels and melanocytes, important in pigment. And you'll see that in like a second. All right, let's move on. I think this is the last page, no? Oh, okay. All right, so the structure of the iris, they have these important muscles that's involved in like constriction and dilation of the eye. Constriction
Mm-hmm.
of the eye, that means like, when you shine a light in someone's eye and their eyes get small, that's
Yeah,
what's
get
happening.
dilated.
Exactly,
Okay.
they're constricting, right? And the muscle that's involved in that constriction is going to be your sphincter papillae muscle, right? They're going to constrict and contract the eye and make them tiny. And then the sympathetic, when you're running from the bear and your eyes dilate,
Mm-hmm.
that's going to be your dilator papillae muscle, right? So sphincter is tiny, dilate is big, right? And that just means when you're running from the bear, you want that eye
Mm-hmm.
to be open. And then this is what I was saying in terms of like the structure of the retina. He kind of outlined this a lot because I think he wants you to know specifically, this is what people like to test in the retina. They like to talk about cones and rods, right?
Mhm.
Your cones is important for visual acuity, meaning like seeing clearly in the middle, right? We're talking about looking straight,
Mhm.
right? If someone is having issues seeing peripherals, that's rods, right? So just know the difference. Centrally is cones, peripherally is rods, right? And your pigment, your melanocytes, your black pigment is going to come from your retinal pigment layer. And usually this is that layer, right? And usually sometimes they have issues where they will separate. Like they have different diseases that separates the retinal epithelium, which is usually important for preventing light from entering the eye, right? Except for the
Mhm.
pupil. The main purpose of the eye is for the pupil to be able to let the light in. But if your retinal epithelial layer is detached, then you're kind of gonna you can be blind by this, or they call it like subacute um blindness.
Yeah, no, this is scary. I knew someone who sold luminous, who was like in medical sales, and they would sell the lasers for the eyes for like eye surgery. I'm like, I don't know if I'd ever want to get like 20/20 vision if I ever needed it, you know?
It's always good to be safe, but I don't know, surgery, I had that opportunity too, but I said no.
Yeah, I feel like it's such a delicate area. I mean, well, everything on your body really, but I feel like the eyes, like,
Yeah,
I'd rather
that
see.
is pretty important. um I can take anything else, not my eyes.
Mm,
Okay, so the cavities in your eye, this is important right here
mhm,
because this is kind of involved in like the fluid flow in your eyes. And then in
mhm,
addition to that, not just the fluid flow, but also like the different kind of diseases associated with this. Like if you have, there's a blockage in like where the fluid usually drains at, which is kind of like what they call, where is that? So this is where the fluid flow. This is your ciliary body, your ciliary processes. This is your muscle, ciliary processes. The ciliary processes, what they're gonna do is they're gonna like secrete these fluid, right? And they're gonna go this way. This is your anterior segment, your anterior chamber. And here
mhm,
is your posterior chamber. Your posterior chamber is going to have your virtuous humor. Your virtuous humor is like this thick substance, right? They like to ask that too. They like to ask you, where is the virtuous humor? You're going to say posterior segment. Where's the aqueous humor? It's going to be the anterior segment, right? This is your anterior chamber, your posterior chamber. So what's happening here when we're talking about like the fluid flow, you're talking about the ciliary processes secreting that fluid, and they're going to come from the posterior chamber, right? This is still your anterior cavity, posterior chamber, and they're going to flow and exit, right, into the
mhm,
anterior chamber. And then they're going to
mhm,
have this thing called like trabecula, or some kind of canal where the aqueous humor is going to go enter and kind of drains,
mhm.
right? And if for some reason they have issue draining, they're going to increase the interocular pressure in the eye, and that's how you get like either open angle or close angle glaucoma.
Oh, wow. That's crazy.
Yeah. So and if usually they'll like drain right here. So what's happening, if they have like close angle glaucoma, that
Mhm,
just means that like that just means that this structure right here like is stuck, right?
mhm,
And sometimes certain different medication can like precipitate a close angle glaucoma, kind of like atropine. Atropine is like a muscarinic blocker. And a
mhm,
muscarinic blocker just means that it's blocking your PNS. And remember we said earlier that in order to constrict meiosis, the eye, making it tiny, right?
Mm-hmm.
That's your PNS,
Mm-hmm.
right? You constrict that muscle, you contract that muscle, and you can accidentally precipitate a glaucoma,
Oh, wow.
right? Because this is your ciliary muscle right here, right? So just imagine, even then, it doesn't have to be close angle glaucoma, but like if there's a blockage in one of these canals, and the fluid can't flow through, it's gonna just increase the intraocular pressure and cause glaucoma.
Mm-hmm.
Um, so that's that one, and then this is just a picture of glaucoma, what will happen. Um, so this is what I was saying when I said if you're if it doesn't drain, you can get glaucoma right here.
And that's from the humor, right?
Yeah, like if the aqueous humor doesn't drain, and they block at the actual canal, the drainage canal right here. Remember, because it comes from the ciliary processes from the posterior chamber to the anterior chamber, and then from the anterior chamber, there's a canal that's supposed to kind of drain
The
everything, but
drainer.
most
Mm-hmm.
often it doesn't. Sometimes it doesn't drain because of a blockage. It could be because the canal blocked it, or it could be because like there's a closed angle glaucoma where the actual ciliary body contracted. And so that could be a issue, and then it could increase the interocular pressure causing the glaucoma.
But isn't that also it comes from like diabetics, right? They get that,
What is it?
or diabetics, is this one of the main things that they get?
Yeah,
Glaucoma.
like they can get this as a complication if they don't take care of it. And that just mainly because
Mm-hmm.
like, most of these are still all associated with the nerve, right? And with diabetics, they start to begin to have issues with nerves, right?
Mm-hmm. Mm-hmm.
So if their nerves are not functioning correctly, it's possible that they have issues sensing, the eyes is gonna have, it's gonna become weak. So that's why it's a later complication, right? With diabetes, you start to think about like ischemia of the nerves. They're not getting enough blood to the nerves. So it's possible to get glaucoma that way.
Mm-hmm.
Yep. So that it was the last PowerPoint for today.
Okay.
I hope I hope that's helpful.
No, it's all your sessions are very helpful to me because I'll either begin my PowerPoints and watching the lectures, or stop halfway before sessions just so I get you to iterate it before I get confused by his lectures.
I see.
So yeah.
So I'm gonna send you this PDF, and then the next one will have the ears, and then endocrine, which will then I will kind of spend more time explaining like that
Mm-hmm.
connection between the adrenal gland and the sympathetic system, so that you can like understand what I'm specifically saying in that, because the adrenal gland is gonna come in a lot more with the hormones. And then I have quizzes, but I know that we're like way beyond our time.
Okay.
So it's up
You
to
want to
you.
do that Saturday? Let's do that Saturday. That way we can
It's closer to your date, huh?
yeah, I think so. And then I think I'd feel confident answering all those questions too. I would have already reviewed by then.
Okay, sounds good. So for today, I had 20, well, actually I had 36 questions. Did I have 36 questions? Never mind.
Ooh, trying to burn me out.
Well, I'll lower it down because some of them are repeat, because
Yeah.
repetition to me is everything. But yes, I'll
Well, you said we have what, the endocrine system and then the ears,
yes, I will send
and then I think that'd be good with the questions, and we could stick with the 36 if that won't run over too crazy time.
wait, sorry, say that again. I missed it. Sorry.
I said I think we could keep the 36 unless you want to break it in half. We do.
I'll break it in half because I think at that time we'll also have the ear and endocrine. So I'll make sure that we I'll do like 20, I'll do like 15, 15, maybe 30 each. And then whatever questions I have left, I'll just send them to you for review. So you're not like, it's not too much.
Mm-hmm. Alrighty.
Uh-oh.
Yeah, that works out.
Let's see. Let me just tag all this stuff in there. I know this was all the notes.
Yeah, all this is no joke, especially with the eyes. I think ever since I got my new MacBook, the new Retina display, I feel like my eyes have been affected so much. Like right now, I don't have it, but I usually have my blue light glasses. I haven't been
Yes, use the blue
using them
light
for
glasses.
our, yeah, I haven't been using them for sessions, but aside from that, yeah, I need to find them again. It's even my boyfriend just mentioned, he's like, you don't have your glasses lately. I'm like, I have like 3 pairs and I don't know where they're at. I think my sisters took them. No, I have lots of thieves here. So, but at my house, yeah, it'll just be me.
I see. Well,
Yeah, I have
so
lots of sisters here.
me too.
Oh yeah, you know how it is with, that's my clothes, that's my hair straightener, that's my curler, that's my hair dryer.
Girl, there is no my.
There is no, you could have this. Oh wait, I want it back.
It's like you gotta borrow back your stuff.
Yeah, or like we're all the same size, like in shoes. Maybe
Um,
shirts here and there, but yeah.
no, we're all the same size in everything. So I'm like, your shirt is mine, your pants is mine, everything is mine.
For me, it's always, I just got it. Thank you. For me, it's like, oh, especially like face products and hair products. I'm like, I have curly hair. You shouldn't be using this. Like, I need it.
You
Yeah.
know, we all live one life. So the way I see it is, hey, I'm not gonna take this to the grave. So you can have it, whatever you want.
I know.
You know, that's how I
Yeah.
look at it, you know. Been that seriously. Like I'm not attached to clothes or anything.
Yeah, no, things come and go. That's
Yeah.
why that's why I'm
Oh,
going to school and doing this, because I like to buy things all the time.
yeah. And just share too, you know, sharing is caring. Um, anyway, you have an amazing night and I hope study hard. If you have any questions, you can always email me, but I will see you Saturday,
Yeah,
right?
I'll see you Saturday. Yeah, that works.
I'll have some
Thank you so
questions.
much. Appreciate you. And then I look forward for the quizzes too. So
Okay,
I like your quizzes. They actually, I feel like, yeah, they help out. They give me a little like a jump start on how his exam's gonna be.
I see. You know, at some point we probably should talk about like, it seems like our sessions are going longer than usual, so.
Yeah. Let me know. I think before, that's what I was gonna tell you. Maybe we should start doing, because right now we're doing 2. We could do 3 during the week. That way we can do
Yeah.
that, unless you are okay with doing sitting down for 2 hours at a time. I think if we
Or we
just do
can
the
do
one
like
hour.
an hour and a half, but I think what we should do in moving forward maybe is starting with the quizzes.
Okay. Yeah. Okay.
Because
That
I
way
think
you
the
know where.
quizzes are like set time, you know, because I think when we're talking about something, it takes longer because of the explanation. But the quizzes, they have to get done in 10 minutes, but there's 10 questions. You know what
Mhm,
I mean? So it's
mhm.
pretty straight to the point. So even if the quizzes, even if like the quizzes are not like amazing in results, that's fine. Like we're not looking for an amazing results like that. We're just trying to get our like things going so that when we then start to talk about it, we're like, oh yeah, that's what the quiz was talking about. Like this makes sense. And I
How
think
to
just
focus
hella
in more.
it will help us be more efficient.
Okay. Yeah, no, that works out. Alrighty. Well, let me know. And then I don't know if you have time or so, but send me like a little Excel or something just to break down how many hours we've had. That way we know if I need to add some more before the end of the semester.
Okay, I
Because I
will.
think I'm week 3, so it's like we're at halfway, basically
Yeah,
halfway point.
I'm keeping track of it, but I will send you sometime this week or maybe tonight or tomorrow.
Okay, yeah, no, just I want to make sure. All right, this works out. Well, I will see you Saturday, okay?
See you Saturday. Study hard.
Thank you. I'll see you.
Bye.
Bye.